This is Preeti and you're watching Math Solution. In this video, I'll be teaching you about the OP poisoning. OP is Organophosphorus poisoning. This is also known as insecticides. Sides means that we used to kill the insects using this compound, so we call this as insecticides. Under these, there are few sub questions which has been asked in the PYQs, that is previous year's questions. For 5-mark question also this is important, and 3-mark question also, that is for a short essay and for short answer. These questions are important. The sub questions under this OP poisonings are the compounds of OP poisoning and the treatment, how we treat that conditions, and the drug of choice, first drug given in that condition, and route of administration of that drug in that drug, and the role of oximes, mainly pralidoxime in OP poisoning. The role of oximes I'll teach you in other video. In this video I'll be covering all these along with the signs and symptoms of OP poisoning. Firstly, we come for the introduction. All OP poisons have no therapeutic use. They are not useful in any condition except this ecothiophyte, which is used in the resistance condition of glaucoma. Ecothiophyte, which is used in the condition of glaucoma. Remaining all are only toxicologically they are important. They have no therapeutic use. And the common OP compounds, which is important for a 3-mark and a 5-mark question, you need to memorize these compounds initially only, because in at the final stage near your exams you cannot remember all these drugs, so try to remember as many as you can. The compounds of OP are parathion, melathion, deflose, serine, soman, and tabun, which is a nerve gas. These are the compounds, OP compounds. OP compounds, what they do means they irreversibly inhibit the cholinesterase activity. You know now cholinesterase break down acetylcholine into acetate plus choline, which was doing the action of this cholinesterase. ACE means enzyme. This is an enzyme which was breaking acetylcholine into acetyl and choline, but this activity is inhibited, so acetylcholine concentration will be increased at muscarinic receptors. There will be increased muscarinic receptors and nicotinic receptors, so there will be increased actions of muscarine and nicotine. We'll see, these are the this is a mechanism how this OP poisoning works. First, initially it irreversibly blocks cholinesterase enzyme. So the breakdown of acetylcholine into acetate and choline will be reduced. Acetylcholine concentration will be increased in muscarinic and nicotinic site. So there will be increased muscarinic activity and nicotinic activity. So the signs and symptoms will be increased muscarinic effects and nicotinic effects. We'll see the signs and symptoms. Signs and symptoms. First, initially I'll say about the muscarinic effects. What are the muscarinic effects? Where will be the like muscarinic receptors will be present. There are, no muscarinic receptors, there are totally 5: M1, M2, M3, M4 and M5. These 3 are functionally important. These 2 are not that important. These are present in CNS, whereas these are present in gastric glands, adrenal medulla and CNS. That is not adrenal medulla, autonomic ganglion and gastric glands, autonomic ganglion and CNS. M2, only single is there. This is present in heart, whereas M3 receptors present in a smooth muscles, exocrine glands and endothelial cells of blood vessels. These are the there is a place where muscarinic receptors. So all these effects will be increased. This acetylcholine, this is a neurotransmitter in parasympathetic, mainly parasympathetic nervous system, as well as in skeletal muscles, the neurotransmitter and the nerve supplying skeletal muscles also. This is an acetylcholine is a neurotransmitter, so all this activity will be increased. First we'll speak about the muscarinic effects. There will be increase in all secretions, like increase in profuse sweating will be there, salivation. This is the function of exocrine gland, which is the receptor, M3 receptor, and lacrimation is also exocrine gland. So the M3 receptors is involved. Vomiting means gastric, M1 receptors are involved. Reflex vomiting will be there. And defecation, of urination, defecation, all those are the these parasympathetic activities, those are increased. And involuntary urination, so involuntary urination. Hypotension, because vasodilation will be there. These M3 receptors are involved. In endothelial cells, M3 receptors will be there. It causes vasodilation and decrease in blood pressure, and abdominal cramps will be there. This is related to GIT. Meiosis, you know, parasympathetic activity. In parasympathetic condition, when you are taking rest or doing something, you are not in stressful situation, there will be constriction of pupil, that is a meiosis. And bradycardia, decrease in the heart rate. When you are in not doing any exercise or anything, the bronchus will be constricted, so less air will be entered inside, and the heart rate is also decreased, because you do not need that much energy, so there will be bradycardia, and bronchoconstriction will be there, and bronchial secretion is also increased. So this OP poisoning will worsen the asthmatic condition. You will be seeing bronchoconstriction and increased bronchial secretion, tracheobronchial secretion. So in asthma, this OP poisoning still worsens the condition, so you have to be careful. And other nicotinic effects will be, nicotinic means nicotine receptors, NN and NM receptors will be there. Mainly I will speak about the NM receptors. This will be present in the this neuromuscular junction. So muscles what they will do, acetylcholine will do contraction, so increase twitching, fasciculations, and repeated acetylcholine action on this prolonged depolarization will cause the muscle weakness. These are the nicotinic effects. And central effects will be, central effects may be related to brain and this. Headache, you will get restlessness, confusion, convulsions, coma, all the CCC, confusion, convolution, coma, and it leads to death because of respiratory failure. Because of respiratory failure, the person may die also. And diagnosis, the person has come with a OP poisoning, how you will diagnose? You have to take a history. History taking is the most important, so that you can differentially diagnose what is the condition without proper this thing. You can by the history only you can say what is the case. So history of the exposure is important. You have to ask properly whether how did the symptoms start, history, and signs and symptoms you have to see for this thing. All the parasympathetic activity, the parasympathetic actions will be increased, and estimates the cholinesterase activity, because this irreversibly inhibit this OP poisons irreversibly inhibit cholinesterase activity, and increases acetylcholine concentration in the blood. So cholinesterase activity in the blood will be reduced. This can be seen. These three are the diagnosis points. And the treatment, what we give, what we do initially when the patient is come on with the OP poisoning, we have to remove the clothes and then wash the surface of the skin with the soap and water, because whatever the poisons are there, they can diffuse into the skin and then they cause still adverse effect. And gastric lavage we have to do only if it is less than 1 hour before after that we are not supposed to do. Gastric lavage should be there to clear what are the poisons that has been already ingested. And airways should be maintained. A, B, C should be there. Airways, breathing and circulation should be we have to see for that. Airways should be maintained. In case if it is not there, artificial respirators if necessary we have to provide. And diapasm we should be given through IV route. To control convulsions we have to give diapasm. These are the treatment for OP poisoning. And specific measures we'll see. Atropine is the first drug we have to give in OP poisoning. That too, we have to give 2 milligrams IV. Startingly, we have to give 2 milligrams. After 5 to 10 minutes, we have to double the dose. That means from 2, we have to give 4. If it is not controlled, if we do not find any atropized patient until he is not atropized, we have to increase the dose. We have to double the dose for every 5 to 10 minutes. For every 5 to 10 minutes, we have to double the dose. 2 to become 4, 4 become 8, 8 to 16. Like that, we have to double the dose for every 5 to 10 minutes until he get fully atropized. Fully atropized means his pupils will be dilated. Now we were seeing all parasympathetic. In OP poisoning, we were seeing parasympathetic activities. Now, if we give atropine to say that he is atropinous, all we should get sympathetic activities. That is, pupils should be dilated and there should be tachycardia, etc. This treatment should be continued till 7 to 10 days. The mechanism we'll see, the like what will actually happen in OP poisoning. OP poisoning, there will be increase in acetylcholine, because no, it irreversibly blocks choline esterase, which was breaking acetylcholine into acetate plus choline. This was breaking, so this acetylcholine will be increased. This goes and acts on muscarinic receptors and nicotinic receptors. We are giving atropine, which blocks only muscarinic receptors, not nicotinic receptors, which competitively block muscarinic receptors. This is atropine. Atropine is an antagonist. It competitively blocks where the blocks the M receptors. Like acetylcholine also should go and act on M receptor only, and atropine also goes and acts on M receptors. There will be a competition between those two and blocks the muscarinic symptoms, but it does not block nicotinic receptor. So it does not reverse the skeletal muscle weakness. This is all about the atropine, which is a specific measure in OP poisoning. The role of oxams in OP poisonings, I'll discuss in my next video. If you are finding these videos helpful, please do like, share and subscribe to my channel. And in this video we have discussed all this except this role of oxams in OP poisoning. That I'll be dealing in other video. Thank you.